Patricia and I'm part of the neurophysiotherapy team based on 7F and 7D. We screen the ward list Monday to Friday daily for new referrals. All new strokes, including thrombolysis and clot retrieval patients, are reviewed by physiotherapy within 24 hours of admission as per the stroke guidelines. We assess mobility and balance and commence acute rehab, plus or minus respiratory assessment if indicated. And we may recommend a referral to rehab including START, which is the InReach rehab program. Physiotherapy is also involved with assessing and treating vestibular patients such as BPPV or vestibular neuritis. Other patients that physiotherapy might be involved with include Parkinson's patients, MS, seizures, MND, Guillain-Barré, myasthenia gravis, or functional gait disorders. You can refer via EMR or we can liaise during daily board rounds. Please specify in your EMR documentation your specific concerns requiring physiotherapy input. You can also page us for urgent referrals.
My name's Elise and I'm one of the occupational therapists up on Ward 7F. I'm just here to chat to you about what we do. So I guess there's a few different reasons that OT will get involved with your patients, but the overarching sort of focus of our role is to just assess if someone is safe to be able to go home, or if they need to go to rehab or respite, or if things need to be put in place to make sure they can leave hospital safely. So there's a few different angles that I would take to look at whether someone is safe to go home. So the first sort of extends on from the physiotherapist role and looks at whether someone can sort of manage the physical demands of being at home and completing everyday life. So this can range from your basic activities of daily living, like can they shower themselves, can they dress themselves, are they able to make a meal for themselves if they live home alone and have upper limb weakness, or things like that. It also then looks at the more complex activities that a person might have to do in their daily life. So for example, if the patient's a mum and she's got young kids at home and needs to look after them, how is she going to manage those sorts of things? And that can often lead into a discharge planning and coordination role, and that often overlaps with the social workers on the ward. So my role is to sort of make recommendations as to what support a person might need in terms of possible services to assist, and looking at whether they can do things in the community that they have to do. So, you know, are they able to access food themselves, particularly like with driving restrictions? Are they able to attend medical appointments? What's going to be the best sort of way to make that happen for them? So just making recommendations along those roles and referring on to other services for help with that. The other side of OT that I think probably separates us a bit more from the other allied health disciplines on the ward is that we look at cognition. So we do that in a few different ways. We do a lot of standardized pen and paper assessment, so things like MOCAs, RUDAS, Cognostats, all those sorts of things to get a standardized score for a patient. The other way we do that is we look at cognition is from a functional point of view. So often I'll take patients across to our OT kitchen on 7E and look at how they do a functional everyday task, something that they should be able to do without issue in a normal home everyday setup. So what's the best way to get me involved? The best way to refer to OT is to put a referral through on EMR, because no matter who is covering, if I'm away, if someone's helping out, we'll all see it. You can pop a page through to 42050, and whoever's on the ward will be able to get that. I do try to screen the list for new patients every day, and with the stroke guidelines, we do try to see all new strokes within 24 to 48 hours. So the earlier that referral goes in, the better. We do also see, so we aim to see all the new strokes, but we also will see any other neurology patients who are referred to us or who need OT input on the ward. And I guess the main thing just to think about then is, from your point of view, looking at function and sort of why you're referring to OT. You know, what's the actual functional implication? What do you want from OT in this point of view? So I guess, you know, for example, if you just want a MOCA on a patient for a baseline measure, maybe because they've had a seizure or maybe just because they're old, or because someone's asked for one, that's probably something a JMO can do if they've got time, just because it's, you know, it's not going to change the outcome for the patient. There's no sort of functional implication or concern that exists if it's just for a baseline. Just because we do have limited staff in the OT department here at Royal North Shore, so in such as we'd like to. We don't always get to see every single patient that requires, that we're referred, so for things like that, maybe see if there's an actual OT need or indication. Similarly, just because a patient is 75 and lives home alone doesn't necessarily mean they need to see me. But if you do have concerns about how they're managing or how they're going to go post-hospital admission, then no worries, pop that referral in and we'll see them. Happy for an EMR referral, but just as happy as well if you see me on the ward, come grab me, come have a chat, verbally let me know if there's someone you want me to see. And same with whether it's in MDTs or case conferences, things like that. More than happy to take verbal referrals. But the EMR, what it does help if I'm away or if another OT is coming and you don't know who to find.
Hello, my name's Claudia. I'm one of the speech pathologists who works with the neuro population, particularly up on 7F, but also down in ICU or ED as needed. Our role with the neuro population is really to provide early assessment and intervention for communication and swallowing impairments. To start off with talking about swallowing, we will provide assessments on patients. Something that we like is for the nursing staff to complete the assist within 4 hours of admission to hospital. The nurses are very good at doing this, but it also helps if in the doctor's notes, particularly with the stroke call, if you could write whether or not you want the assist to be done before having any oral intake or medication. We'll also respond to concerns on the ward that are raised by either the nurses or the doctors as to whether or not they have any concerns with the swallow. So we'll go in and we'll provide we'll start off with a bedside assessment, so looking at them clinically, and we will provide recommendations from this bedside assessment as well as possibly doing instrumental assessment. So we will sometimes do a FEES on a patient or book them in for a modified barium swallow. Now, to refer for a FEES, you can just contact us and let us know if you think they would need it. If you think that the patient would benefit from a MBS, the modified barium swallow, either we'll tell you or you can tell us, and we would need a doctor's referral to do that MBS, which you can find on EMR. Now, what we do sometimes find is that we'll go in and do an initial assessment, or even after a few reviews, and we'll recommend that the patient is nil by mouth, and we'll come and we'll talk to you about that as well as talking to nurses. And really, when we say nil by mouth, we also mean no medication orally. So I know that it can be tough, but it's finding alternative routes as available. Otherwise, sometimes these patients will need an NG put in to them. So we'll do all the early assessments and we'll keep seeing them and providing reviews as well as therapy as it is appropriate for the patient. The other thing we do is do communication. So we often see communication impairments post-stroke. We see language impairments, which we call aphasia, dysarthria, the speech impairments, or if there's a voice impairment or a COG-COM impairment. So we're really heavily involved in all of those early assessments and again, early intervention for those ones. If you need to refer to us, you can refer for us on EMR. Otherwise, there's always someone who tends to be on 7F. So just
Role of the dietitian on the neurology and stroke ward is to provide individualised nutrition care while they're an inpatient. And usually for neurological disorders, they're often frequently associated with swallowing difficulties and often malnutrition. So dietitians are able to assess and provide support. And we work really closely with the speech pathologist when a patient's on a texture modified diet, for example, a puree diet, or they might be on a thickened fluid modification, like mildly, moderate, or extremely thick. We're able to identify nutritional issues experienced by neurology and stroke patients and provide advice on these. We're able to assess and diagnose malnutrition, and we're able to prescribe nutrition supplements if that's appropriate. As a dietitian, we're able to identify indications for enteral feeding for patients and definitely advocate for that if it's clinically appropriate. And we're able to provide enteral feeding regimes as well as parental nutrition regimes as well. We're able to help and manage refeeding risk, especially on the ward, and provide nutrition education as well. So When to refer to a dietitian. So definitely refer to a dietitian if there's a new enteral feed or a parenteral feed on the ward. They're definitely our top priorities and we'll see them really fast. If they've got a history